Well, we heard from our starting panel that workforce is definitely one of the challenges among the many challenges in the healthcare arena, and we certainly know that it even affects all businesses across Montana as our low unemployment rate impacts the ability to hire individuals that we're seeking with the skill set that we also need. But certainly Montana is facing an overall workforce shortage crisis when it comes to the healthcare industry. And up next is our Healthcare Workforce Demands panel with the University of Washington's Dr. Suzanne Allen, Carol Bischoff with HealthCare Montana, and Chris Juliar of the Montana Area Health Education Center and Office of Rural Health, who will also serve as our moderator for today's panel. Chris, I'll hand it off to you.
Turn it on. Okay. Hi. Well, welcome everyone. I am Chris Juliar from the Montana Office of Rural Health and Area Health Education Center at Montana State University. And one of the programs that we run there is the Montana Healthcare Workforce Advisory Committee, and we have several of our members of that advisory committee are here in the audience today. So we know how important this topic is to Montana and how complex it is, and I'm really pleased with our speakers that we have today to address this. You may think, as we discussed it, Carol will be talking about the programs that are being developed under a program from the Department of Labor around community colleges, and Suzanne will be talking about medical school, that those are on kind of opposite ends of the spectrum, but in reality these programs work very well together and address many of the same issues in this state. And we're also very pleased that we're having this discussion on National Rural Health Day, and Carol's wearing her National Rural Health Day t-shirt, which is a national effort to recognize the importance of rural health, and the slogan for that is the power of rural, that rural areas can be leaders in creating solutions to rural health, to healthcare issues, workforce issues in the country. So I'll start our presentation. Suzanne Allen, she's appointed to the position of Vice Dean for Academic, Rural and Regional Affairs for the University of Washington School of Medicine in February 2015. We work here with Suzanne in Montana with the WWAMI Medical School Program, which stands for Washington, Wyoming, Alaska, Montana, and Idaho, as regional campuses of the University of Washington. She's responsible for the program across the 5 states. She is a clinical professor with a faculty appointment in the Department of Family Medicine and is a practicing family physician in Boise, Idaho. And Carol is the workforce coordinator for HealthCare Montana. It's a 3-year grant designed to bridge the healthcare workforce skills gap by helping job seekers and community colleges work together to develop the programs that we need to address the healthcare workforce needs in our state. Before becoming involved with the HealthCare Montana project, she was employed by the Montana Hospital Association as a Medicare Rural Hospital Flexibility Grant Coordinator working with the critical access hospitals. She's a registered health information administrator and has been an active member of HIMA, and chair of the NRHA, looking at mine here, and has a BS degree in food and nutrition from North Dakota State University. So I'll turn it over to our speakers.
Great. Thanks so much. I'm happy to be here with all of you today to talk a little bit about physician workforce. So first, just to make sure that we're all on the same page, to become a physician, you have to finish 4 years of college, then you go to medical school for 4 years, and then you have to do at least your residency training, which is 3 years if you're going to become a primary care physician, and then you can go on and do fellowships after that. So we know it takes at least 11 years from the time someone graduates from high school to become a practicing physician. That's important just as we look at what changes need to be made to improve the physician workforce. It's a long time before you actually see any outcomes outcomes unless you're doing different things along that path during those 11 years. The other challenge when we look at making changes in how we work on the physician workforce is what it takes to actually develop new programs. This is just a slide depicting what it takes to go from being a pre-medical student to being a licensed practicing physician, and all the different organizations that come in along the way, largely that deal with accreditation of different programs that you may need for your training, or different programs dealing with your licensure. So now just looking at what do we have here in Montana, the current physician workforce. So right now Montana ranks 35th in the country for the number of physicians per 100,000 population. And if you look at the active number, you go up in rankings to about 30th in the country. That means that the physicians you have are largely seeing patients, which is a good thing as far as utilizing your physician workforce. You can see the number of primary care physicians per 100,000 population is about 82. That ranks 27th in the country. And then your active surgeons per 100,000 population actually puts you at 9th in the country, which is great since general surgeons are kind of a dying breed. There are fewer of them being produced in the country overall. So to have that number here in Montana is really helpful. One of the alarming things on this particular slide is the percent of the physicians in the state who are over the age of 60. So right now there's around 2,400 physicians in the state of Montana. If you look at a third of them retiring in the next 5 to 10 years, that's about 800 physicians who will need to be replaced. And I'll talk about that a little bit more in a few slides. So what about medical education? So that pipeline to actually create those physicians to work in the state. Montana sends about 55 students to an allopathic or MD granting medical school across the country each year. 30 of them are in the WWAMI program. 6 of them OCHI supports through the WICHI program. We send about another 20 students to an osteopathic or DO granting medical school somewhere in the state, and OCHI supports 2 of those through the WICHI program. So about a total of 75 Montana residents per year go somewhere in the country to go to medical school. If you look at the numbers of the neighbors to the east, North Dakota and South Dakota, they actually have smaller populations than the state of Montana, but send more students to medical school across the country. Certainly in allopathic, it's a little bit harder to find the osteopathic numbers. So one of the things just in thinking about how do we create that physician workforce is even working at that pre-medical level, how do you get people even interested in going to medical school, get them from high school into college, successful in college, to even apply to medical school as the beginning part of that pipeline. So next is looking at GME, or the residency programs, which is kind of the next point in the pipeline to having practicing physicians. The great news here in Montana is that in the last 10 years, the percentage of residency positions available in the state has gone up 320%. That's the most of any of the states in the country, so congratulations on the hard work I know everyone has been doing around that. Back in 2006, there was only the family medicine residency program in Billings. Since then, there's the family medicine residency program in Missoula, as well as the internal medicine residency program at the Billings Clinic that have started. The other great thing is that Montana ranks 3rd in the country for keeping graduates of their residency programs in the state to practice. So if people come here to do their residency training, they're very likely to stay here. Over 60% of them stay here to continue practicing. So Montana is only behind California and Alaska as far as keeping the graduates of the residency programs here in the state to practice. So what does it cost for the medical education that we currently have here in Montana? So it's around $5 per capita that Montana spends per year between medical school and residency training. If you look at your neighbors to the east with North Dakota and South Dakota is around $26 per capita, and North Dakota is about $37 per capita. The interesting thing is that you have more physicians here in the state of Montana compared to what North Dakota and South Dakota has, and you spend less money per capita to get that. So while North Dakota and South Dakota have their own independent medical schools in those states, they actually don't have as many physicians per 100,000 population as the state of Montana does. So there's more than just having a medical school that helps to create your physician workforce. So just looking at the Montana WWAMI grads and thinking about what do you need in the state of Montana, you can see here just that of the WWAMI grads, we have a high percent that go into family medicine and internal medicine, which are the two bars to the right of that particular graph. If you think about what the workforce needs are in the state of Montana, and think about the rural areas, you know that there are a number of counties in the state that do not have any practicing physicians in them. Having generalists who can go out and take care of most things that walk through their door makes the biggest difference in providing high quality, cost-effective health care to the citizens of the state. Right now in Montana, the primary care physicians do pretty well distributing themselves between urban and rural, with urban having around 80 primary care physicians per 100,000 population and rural having about 78. So that's about as close as you're going to see in most places around the country of a distribution of your primary care physicians. Of course, if you look at specialists, that number is going to be slightly different. Specialists tend to need a larger patient population to support their practice, so they tend to locate in urban areas much more frequently than rural areas. If you just look across the country. So I'm going to stop there and turn things over to Carol, and I look forward to our conversation after Carol's presentation.
All right. Thanks, Suzanne. Okay, so first of all, my name is Carol Bischoff, and I am dressed down today, but I'm such a rural health geek. I do actually have a rural health t-shirt, so I thought today would be a good day to wear it. So here I am. It is an important day for Montana, given our rural and frontier nature, and I encourage all of you as you go through the day to remember and think about Montana's rural health care providers and facilities, issues in the healthcare delivery system that may be discussed today at this conference are magnified for our rural neighbors who face continual budget and workforce challenges. So just please keep their interests in your brain. Anybody in the room familiar with the HealthCare Montana grant? Raise your hand. So there's a few. So we need to hit the refresh button. I'm already speaking in the past tense. We have about 5 months left in the grant. It was a 3-year, almost $15 million Department of Labor grant, a TAC 4, which TAC is the Trade Adjustment Assistance Community College Career Training Grant, and this was round 4. Round 3 focused on manufacturing. It was awarded to Missoula College in September 2014. The goal was to strengthen our 2-year college system by transforming from a fragmented, localized healthcare workforce development model to a statewide system of workforce planning. We have 15 community college partners and 200 plus healthcare employer partners and several industry partners, including the AHEX, OCHI, and the Montana Department of Labor. So, when I saw Suzanne's presentation, I thought this was really a nice combination because this is focusing on physicians, whereas our grant is focusing on nursing and allied health. So we don't do anything with physicians. Okay, so the next slide shows you the map of the community colleges in Montana that are partners. So they're all over. The next is a map showing our employer partners. We have relied, which has been pretty much my role with this grant, is to help engage the rural healthcare providers around the state. So you can see we've got providers from all over the state, all types of deliveries, from the large hospitals to critical access hospitals to clinics, nursing homes, et cetera. And this is our current numbers. We're directly serving 3,165 participants, and we actually have 130 healthcare apprenticeships. Healthcare apprenticeships are very new to Montana. When we started the grant, there were none. And we now have 130, and I'll spend more time talking about that process a little later. So it's been a real innovative feature of the grant that has gotten some national recognition. This is a little bubble graph that describes our desired outcomes. And we had the 10 focus areas in the circles around the outside that are really divided into 3 categories: student support, healthcare industry engagement, which again was kind of my purview, and curriculum development, which was a very arduous process, and the nursing curriculum changes are complete and in place, so that is hardwired, and the allied health curriculum changes, which again I will talk about, are almost there. So, getting right into the nursing curriculum redesign, we created a practical nurse certificate of applied science. We have 5 colleges offering that PN program in a variety of methods, 3 via distance, hybrid, and 1 student is doing this as an apprentice. So we actually have a PN apprenticeship program, which is very new. And the 5 campuses are Great Falls City College in Billings, Flathead Valley Community College, Blackfeet. We do have 4 tribal colleges that are partners, and Helena College. This was a very serious body of work that was conducted very early in the grant, and we're just now seeing some PN students graduate. I think we'll have our first graduates this December, and then with more coming in the spring. So it took a long time for the nurses at both the campuses and nursing representatives from healthcare providers to work through those curriculum challenges. Let's see, so the PM program is separate from the ASN. What the committees did was reduce by 1 semester the prerequisite courses. And a lot of this, one of our focal points has been moving this to a distance delivery format so people can stay in their communities and get their education. Excuse me. The ASN to BSN completion was reduced by 1 semester, also offered via distance. They can complete the BSN in 8 semesters and can work as an RN during the BSN completion. They used, we did a lot of work with prior learning assessments to kind of help speed the students through their educational programs. One of the challenges we had was how do we generate enough clinical site experience for these nurses? So we really relied on the employers, which, having worked with rural healthcare for so many years, I always say that's where the creativity sits. If ever you want something new and innovative, you need to call on the people in the rural communities because they've been doing this forever. So the employers and the nursing directors at the campuses got together and created a clinical resource registered nurse training. They did the initial training up in Great Falls with a huge success, and now Helena College has taken this on as one of their programs, and this is offered, the training now is offered online, and it's a regional concept so that there'll be somebody in the regions that can facilitate clinical experiences. I've got their website there. They are, I think that last I heard they had like 13 people signed up for that, so that's pretty cool. The umbrella that I've been working under is local employer engagement, and We have workforce coordinators that are located across the state. And our initial project was to conduct some needs assessments. We did about 125 across different settings. And from that, we directly used the input from providers to help create changes in curriculum. The one, of course, near and dear to my heart was we heard loud and clear from the providers employers in rural communities that their staff didn't understand what it meant to work in a rural setting. And so we took that back to the committees, and they were able to create a portion of their curriculum that did focus on, you might go from from an AMI into the ER to an ear infection in the physician's office, just in a matter of minutes. So the need to switch and the need to wear many different hats. This is the one feature of the grant. The curriculum changes will be hardwired. The workforce coordinator position that we use for the bridge between campuses and employers is the one feature of the grant that we are working real hard to try to sustain. We've identified this as a real key to success for projects. I think heretofore there had been minimal conversations between employers and campuses, and this has helped make a bridge between those two. We relied so heavily on the employers across the state for feedback, and we not only did the initial assessment, but we also asked them to serve on committees, which they did. We tried to make it easy for them, so we did most everything virtually, recognizing their time is precious. And the other thing that we did was created a rapid response survey system, and I think we've done maybe 30, 35 of those. Early on, it was about curriculum changes, what their needs were, what they wanted to see, and that directly fed into the committee work in committee and curriculum changes. Let's see. Moving on. So distance education, I've mentioned, that is one of our key elements that we've discovered. That was one thing the employer said we can't send people off. If you could keep if they could stay home and do their studies here in Culbertson or wherever it might be, that would be great. So we have worked with campuses to develop, in addition to the distance PN program, we have the CNA specialties are available via distance. We also have some success skills modules. One of the things the employer said was their employees lack soft skills. We preferred to call it success skills. So we do have success skills modules that are available for free. CNA is available through distance. Community health worker is almost there, very, very close. And behavioral health aid, which was a real that came out of the South Central region of the state. They were the impetus to create coursework to help providers become more astute at dealing with behavioral health patients. And most of the allied health core curriculum will be available via distance as well. All right. We did a lot of work with the military crosswalk, so that one of our key target audiences were veterans. And so the Board of Regents did pass the prior learning assessment policy that was implemented at all the community colleges. And now we've had some serious work done on translating work that corpsmen and medics have done in the military to move them through their nursing programs quicker. Okay, and then this is just a very brief outline of the core curriculum work. This had huge employer input. The idea here was to create a core curriculum for a number of allied health professions so that they all started with the same set of courses, and this is all available online. And It gave the opportunity for students, if they weren't quite sure they wanted to be a rad tech, they could at least start and they could get the taste of what that might be like. And all of these credits are transferable, easily transferable throughout the campus, the Montana University system. So there was just a lot of alignment of those prerequisite courses. This took a lot of examination of what the different disciplines needed, the disparities, and of course we have to, for these allied health professions, need to think about their certification and licensure. So we're provided the assurance that they would be, they wouldn't have issues with that going forward. And now on to apprenticeships. This is, again, our poster child, our star program. We do have 130 plus apprenticeships across the state. 40 different employers sponsor these programs, and I've got the occupations listed there. I'm not going to read them. This was a very challenging program. As I said, there were 0 healthcare apprenticeships when we started. It took a lot of work just to create identify employers and work through the curriculum and develop the standards. And then the Department of Labor has a whole registration process to go through. So it took a long time just to get that first one done. But once that was complete, the rest fell into place quite easily. Well, not quite easily. I didn't do this work, so I shouldn't say how easy it was. It took a while, but now that we've got the format anyway, it's at least a pattern. So here's a map of where all of the apprentices are, all over the state. And we just did a little survey of the employers, and this is one thing that they seem to be pretty delighted with. They recognize that growing their own staff helps with retention, they're still employees, so they can still work. They can still put in a few hours every day. We have a strong relationship with tribal colleges, and I'm just listing some of the work that they've done. Chief Dahlknife developed an addiction counseling program. Salish Kootenai has EMT, medical assistant, CNA programs. Stonechild, EMT and coding apprenticeships, which was very exciting. Blackfeet has a boot camp for their nursing students. And Ani Nakota, which isn't technically a partner, but they did a lot of work with developing the nursing curriculum changes. And just very, very briefly, one of the ways we moved the grant programs, tried to move to achieve our outcomes, was to ask that each campus take on a project. So this is just a list of the projects, and there was many of these were the result of the campus's conversations with local employers, which was kind of the goal. Let's see, I think I have 2 slides. This is, there we go. And then there were 19 enhanced programs, so I'll just let you read through that list. These are still underway. These are not complete. We still have a little bit of work to do in the last 5 months of the grant. So speaking of the last 5 months of the grant, where does this go when the grant dollars go away? We are looking to the Health, Education, and Workforce Coordinating Council as a possible venue for at least the execution of the strategic plan, which was also one of the activities we completed as part of this grant. It's the HealthCare Workforce Strategic Plan. It's on the AHEC website. We're working with representatives from that council, namely Chris, to determine what activities should be sustained and how we might sustain them. And there's the list of the purpose that the coordinating council has developed. I can let you read that too. The members of this council include a lot of folks from education, a lot of Deputy Commissioner John Seck, Clayton Christian, a number of other folks from campuses, Chris, and then some industry representatives such as Jean is on this council as well. And that's the summary of our grant.
Thank you, Carol and Suzanne. I've got a couple questions, and then we'll get some questions from the participants in the conference as well. Suzanne, I know you're involved on a lot of national committees and programs, and sometimes we get kind of stuck looking at kind of our issues in our own state here in Montana. But what do you see on a national level that is important to states like Montana as they look at how to address their need for a physician workforce?
Yeah, thanks, Chris. Back in 2005, the Association of American Medical Colleges said we're going to have a physician shortage. All medical schools should expand by about 30%, so that by 2015, we're graduating 30% more physicians in our country. So medical schools around the country did expand, including here in Montana. The WWAMI program expanded from 20 to 30 students. Notably, there have been a significant increase in the total number of medical schools in the country, with about 20 new medical schools on the allopathic side that have opened in the last 10 years, and a number who are considering opening in the near future. On the osteopathic side, they've doubled the number of graduates and still have plans to continue to expand on the osteopathic side as well. So total, we will have expanded the graduates of medical schools by probably over 40% from 2005 to 2020. Residency programs are that next step, is where we're going to run into the bottleneck, if you will. So residency programs have continued to expand, but only by about 1% per year during that period of time. So what does this mean? It means that at some point in time, I think the year being quoted right now is 2022, we're likely to graduate more medical students in our country than we have first-year residency positions for them. So I think looking here at what Montana has done, Chris, is huge for the state in saying, how do we take that next step in the pipeline of creating a physician, which is the GME portion. The other thing, if you just look at the great retention rate here in the state of Montana for residents, it's a much shorter pipeline if you get somebody from a different medical school who comes here and does their residency training for 3 years and then decides to stay, rather than that entire pipeline across the 11 years that it takes after high school. So I think that's one of the things Montana is doing really well right now. I think one of the other things that everyone just needs to be aware of is what a physician does looks much different today than it did when I finished medical school, which was just a few years ago. So if you look at that 35% of your current physician population that's likely to retire in the next 5 to 10 years, especially if you look at a rural family physician, that's someone who's been doing everything, has probably been on call every other night, every third night, depends upon who they have in their community with them. People who finish residency training currently have had work hours, so they're not allowed to work more than 80 hours in any given week. They can't be on call any more frequently than every third night. Once they're on call the next morning, they have to go home. They can't work the following day. These are all good things from a patient safety standpoint, but from a workforce standpoint, those graduates, when they go out and look at practice opportunities, they don't want to be on call every third night because the majority of them haven't been on call that frequently during their residency training. And if they do have to take call, they don't necessarily want to see patients the next day. So if you just look at replacing one physician who graduated from medical school in 1970 with someone who graduated from medical school in 2015, you probably need at least 1.5 physicians to replace the one, if not 2. So that's the other thing in just thinking about the physician workforce is how do you maximize what the physicians are providing as far as services, realizing that many of them have a different thought about what their work-life balance will be than people who finished medical school 40 years ago. And I'll stop there.
Okay, great, thanks. And now a question for Carol. You, in your work over the last 3 years, have had a huge opportunity to talk to employers across the state and engage them in thinking about the preparation of the healthcare workforce that we need. What would be some ways that you have found that have been really successful in getting employers engaged, and how to keep them engaged with looking at the healthcare workforce issues in our state?
I would say that the KISS principle applies. Keep it as simple as possible and quick as possible. We learned quickly with rapid response that checklists. I mean, even though it's not the best, we're at least getting a response. And truly, I think if you make the projects meaningful and task-driven, I think the employers really appreciate that, and because they recognize it's their lifeblood. So if they don't have any providers, it's a little hard to take care of patients. So I think that there's motivation out there. I think the time is right. Providers and employers are ready to come to the table and really want to see something constructive done, which I think is another key. But I think really the ultimate for them is their time is so precious. You need to just make sure that it's brief, succinct, and to the point.
Thanks. And could you both say a little more about the role of our healthcare organizations in education, and some of the things that rural and the larger facilities are doing to participate in educating our next wave of employees and physicians and healthcare professionals?
Yeah, sure. Thanks, Chris. And thanks to all of you who work in health systems that currently help support medical education, whether it's pre-medical students who are doing shadowing work, medical students who are out doing clinical training, or residents who are out doing clinical training. We know from studies that the more time someone spends in a rural location, the more likely they are to go back and work in a rural location. One of the things that is helpful for all of you to be engaged with is finding people who are accessing your health systems, who you think will become a good professional to work in your system in the future, and encouraging them along the way, whether it's in an allied health profession or whether it's becoming a physician. If we get them to come from small communities, they're more likely to go back and work there. So that's something that everyone can help in doing. I always tell students that I'm working with, residents or practicing physicians, that if you're not actively recruiting the people who are going to replace you someday when you want to retire, you probably are going to have a harder time retiring. So it's something we should all be working on. The other thing is really being as supportive as we can of people doing their clinical training. So certainly with the WWAMI program, we try very hard to get our students out into small and rural communities to do their clinical training. I know the residency programs in the state are great about getting residents out to do clinical rotations in those small communities, and certainly Senator Tester's office has been very helpful in trying to get some legislation passed to help make that happen. So I think continuing to provide opportunities for people to do clinical training is one of the big things that really makes a difference in the future workforce.
I would just say I agree 100%. The nurses also need clinical experience, and I think the idea that we can be creative with that and still meet the requirements is just really, I think it's out there. I think there's probably other options that might work aside from what we developed within the grant. But I think being supportive of your community and the desire for, we've already seen success with people that come up from their community and they want to stay there. Their husbands are ranchers, they've lived there forever. So that I would agree with Suzanne.
Then another question I have for both of you is, we've been talking about education that starts at the college level, but how important is it to start, and when should we start with the kids who are coming up through our high schools and getting them involved in and kind of what's a role for employers also in these pipeline programs?
I'll take this first. It's very interesting that you should ask that question, because we are right now surveying our employers, and that's one of the things that they brought up is they would like to see more work done in the high schools, even down into the grade schools, to encourage students to go into the health professions. So the employers see the need to do that. I think that's a very critical piece.
I would just add, there are some studies done looking at when you have to get people interested in math and science for them to do well in math and science in high school. And probably if they don't have an interest in math and science by the 5th or 6th grade, it gets more difficult to get them interested later in high school. Not that you have to be great at math and science to go on and work in the healthcare field, but you do have to pass a number of prerequisites if you want to become a physician, probably for nursing school, physical therapy school, pharmacy school. So there are some prerequisites that you have to be able to do well in when you get to college. In those STEM areas, that if we're not doing things to help people be interested in elementary school, we probably are not starting early enough. The other thing I would just say is that many people, if they don't have anyone in their family who has done anything in the healthcare field, they may not be aware of all the opportunities there are to work in the healthcare field, because people may say, well, I don't really like blood, I get queasy. Well, there are lots of things you can do in healthcare that have nothing to do with blood. So really, having those health career fairs, if you will, when students are in junior high or high school, or health career camps where they have the opportunity to explore different health professions, really makes a difference. We know that the mouth was taken out of the rest of the body a long time ago, and we know that dental health is extremely important to your overall well-being. There are lots of studies that link heart disease to bad oral health. And that's one of those areas where when people think of healthcare, they don't think of dental care, but really we should try to put the mouth back in the body. Similar to behavioral health, which we've also kind of pulled away from the rest of the body, and again, we should be putting back. So helping people at a younger age think about a broader healthcare system and job opportunities, I think, is very important.
Well, I could ask many more questions, but at this point, I'll see if there are questions from the audience for Suzanne and Carol. Yes.
Is there any worry about the GOP tax plan when it comes to interest? Student loan deduction? To getting people into those positions? I guess getting people into those positions when you're worried about this new tax where you won't be able to take that interest out of your tax payment?
Sure. I think the question of student debt, if you look at what people graduate from medical school with for debt, the average around the country right now is $180,000 that a medical student graduates with. That's just medical student debt. On top of that, they may have college debt. So most of them opt to pay off their student loans over a 20 to 30 year period of time, meaning most of them end up paying close to $300,000 or a little bit over $300,000 in overall debt payments for medical school. So certainly students are concerned about this. They worry about what that means, kind of overall, what's their learning or earning potential. And the big thing I worry about is, can we get people to go into primary care where we know we need an increased number of providers, and can we get them to go work in rural areas where they may not make as much money? When they think about things like that, are they going to be able to take that their loan payments out of their tax returns? So it may have an impact. It's so hard to know until something like that actually occurs.
Other questions? Yes, Sarah?
So I'll try and project loudly till the microphone comes. So this of this was going on. So congratulations. It's an outstanding amount of work. It really is. So my question is, are there other grants like this in other rural states, thinking of Wyoming and Alaska in particular?
Well, this again was a TAC 4, so that means fourth round of this set of grants. I've not heard any availability for TAC 5. There's nothing that I'm aware of. This round of TAC grants did focus on healthcare across the country. It was available to other states, but it's done. TAC 3 was manufacturing, and I don't know what TAC 1 and TAC 2 were. So it's pretty much, who knows on the horizon what might be available, but for now, this series of funding through the Department of Labor is done.
And as far as I'm aware, Wyoming and Alaska did not receive these grants. Yeah.
I'm wondering if you could comment on the role of team-based care, like patient-centered medical home type of practices, and what kind of impact that will have on access to health care. Do you want me to go first?
Thanks for that question. Certainly, as a practicing family physician, I can't do my job without everyone who helps me accomplish that job. I'm very fortunate that where I work and see my patients, we have a very integrated system. So we have behavioral health on site. We actually have psychiatrists who practice in our clinic. We have pharmacists. We have dietitians. We have social workers. So from the standpoint of being able to provide full care to the patient in a team-based fashion, it makes a huge difference to what I'm able to do with my time and the services the patient is able to receive beyond just being able to see me. I think if we're not moving towards that model of integrated care, meaning everything is available to our patients in one location, I think we're duplicating efforts in many ways, where we should be working smarter together with the resources that we have available. I actually think it's a much better patient experience as well to be working in an integrated clinic. I think the challenge that we continue to run into when we talk about interprofessional education, which most of our professional schools now have an accreditation standard saying you have to have interprofessional education provided to your students. Our challenge is this ideal picture of what interprofessional team-based care is versus the way things are actually practiced the majority of the time. And so trying to model for students really what an ideal setting looks like, it can be challenging if you don't have enough practices who have already made that transition. And I could talk a lot longer, but maybe I'll stop there and see if Carol has something to add.
Yeah, that's a very good question, and that was actually one of the things that the employers identified on their initial assessments was the need for their employees to be able to work as a team, and they felt that was not maybe as strong as it could be. So that went directly to the curriculum development committees who actually built into their curriculum what it means to be on a team, how a team works, et cetera. So those courses were indeed added to the curriculum. So that's a good thing.
I'll comment too that the Healthcare Workforce Advisory Committee has taken this up on a periodic basis to just look at what is the impact of the new care coordination models, population health initiatives, patient-centered medical homes, ACOs, on what our workforce should look like. We're kind of educating. Education doesn't turn on a dime, and so are there different roles? Are there different professions that are coming to the forefront? And how are we addressing those? So looking at, for example, who's doing the care coordination? Is that nurses, social workers, medical assistants, other people? We're looking now at the role of community health workers and those paraprofessional roles and the way they fit in. So I think it is, you need kind of this just-in-time kind of rapid response to keep on top of what's the very rapidly changing environment in healthcare, and how are we responding to that and developing the workforce we need for that new environment.
Well, let's give our panel members a round of applause. Just the mic here. No, I just want to reiterate, I think the question on teamwork and working as teams is really important. And that is a cultural shift that has to happen in a healthcare system. And we all know that doing that kind of cultural shift takes time. And it takes a lot of concerted effort from the very top to the very bottom to move in that particular direction. At the Montana Medical Association, and it was actually at the request of one of the leaders at the Billings Clinic, suggested that we ought to put together a physician leadership program in the state. And we started that and are on our 5th year of doing that. And the particular purpose of that is this transformation that needs to happen out there. And so we have had over 80 physicians participate in that. We've expanded that out now to include dentists, APRNs, and physician assistants. And we're working and striving to make sure those practices that our residents are going into are headed in that particular direction. And we appreciate that. We have Jack King in the room, and one of the things that he's doing over at MHA is also picking up this theme of building teams, and he's actually launching also a leadership program patterned off of ours as well that's going to focus on the critical access hospitals, bringing together medical leadership, the CEOs, and also their board members, and doing the same kind of themed work. And we know that that's going to be also transformational out in our critical access hospitals. So just want to applaud the work over at MHA and Jack King on that particular effort as well. One thing that we talked about is, again, our unique partnerships across our state. And one thing that we know is that it takes a community to recruit a physician. And recruiting a physician is pretty darn important, because once you get a physician in your community, the economic benefits are quite strong for your community. I believe it's over $1 million of economic benefits to that. And one thing we noticed when we were going around with our physician leadership program, we go around the state so that physicians have exposure to how care is delivered in different parts of our state. I'll never forget the chance that we had to go to the beautiful town of Lewistown. We brought forward physicians in that town to talk to our physicians about why they chose a rural facility to practice in. And that physician said it was because of the community. And it was the embracing of my spouse by that particular community that made the difference. Not the hospital system uniquely situated to recruit that physician and bring that spouse in, but the community itself. When the church ladies came forward and said, we have a place where you can come and network with other females, and we have a place where your child can go a couple of times a week and get some programs and support. And they also had the librarians come forward and said, this is what we have also offering at night for your children, and they had very young children. And the school system also came forward, and businesses. And that's what made a difference for that physician who chose to practice in that community versus another community in Montana. He was a Montanan, and he was intent on coming back to Montana, and that kind of goes to Dr. Allen's piece of growing our own and how important that is as well. So we appreciate the partnership and, again, a key way that businesses and healthcare can work together to address our workforce pieces. I want to thank our individuals up here. AHEC is such a tremendous resource to our state and the work that they're doing in all kinds of particular areas. And Carol and Suzanne, thank you for the work that you related and the ongoing strides we're making to build our healthcare workforce. Thank you.